Good morning, everybody. In the life of phacosurgeon, many a times comes a situation when it appears almost impossible to do a successful intraocular lens implantation. One such challenging situation was a case where during IOL implantation, lens implantation in the eye, we find that the trailing haptic was dislodged from the optic. It was a challenging situation as in the anterior chamber lens optic was there and one haptic was in the back. The another trailing haptic was dislodged from the optic. Now the question was what to do. The alternative was number one, we have to remove the lens in two parts or multiple pieces, 2 or 3 pieces, and then to remove the lens from the anterior chamber and to implant the another lens. This situation comes because this was a multi-piece lens. The second situation which came in our mind is the haptic was dislodged from the optic and the haptic was not broken. So we have decided to remanufacture or to reconstruct the lens in the anterior chamber. Here, after cataract removal, whole epinucleus was aspirated with the help of IA cannula. I am using coaxial irrigation and aspiration cannula to remove the epinucleus as well as the cortical matter. This was a posterior subcapsular plaque cataract, so we took utmost care not to induce the posterior capsular defect or posterior capsule rupture. So first we removed nucleus, then epinucleus, and then cortex one by one in all the quadrants, and lastly the central portion of the posterior subcapsular plaque opacity. This is the completion of cataract removal. Now to implant the lens. The posterior capsule was also polished with hydrojet. Now we are implanting the three-piece intraocular lens, and now here you can see the haptic was in the plunger and it was dislodged from the optics. So this is the haptic which is dislodged from the optic. The optic is in the anterior chamber and one of the haptic is in the back. So first I dislodged the haptic from the anterior chamber and then I rotated the lens and we decided to remanufacture or reconstruct the IOL in the anterior chamber. This was slightly a difficult task. To hold the lens in the anterior chamber and to prevent the posterior capsular rupture, because this is a multi-piece lens. A slight jerk of the lens in the anterior chamber can rupture the posterior capsule as well as can give the trauma to the endothelium. But we were lucky to reconstruct the lens there only, and with the help of Sinski hook and Y hook we were able to implant the lens in the back successfully with a successful post-operative result. At this time we were not having viscoelastic like Viscoat and Hilon GB. If we were having the availability of viscoelastic, that might be more useful for me to reconstruct the lens, just to avoid the jerks of lens in the anterior chamber. But with patience and good wishes of all of you and God, it was possible for me to reconstruct the lens in the anterior chamber and to implant the same lens in the eye. After implantation of the lens in the back, we just checked the stability of the lens. It was fine. Thank you very much.